Welcome to this medicine masterclass on myasthenia gravis. Myasthenia gravis is an autoimmune disease mediated by antibodies to the postsynaptic nicotinic cholinergic receptors. This interferes with synaptic transmission by depleting acetylcholine receptor sites. Antibodies and immune receptors are mediated by both T and B cells. Patients with myasthenia gravis present with increasing muscular fatigue with repetition. The muscle groups affected start with the extraocular muscles, and that's why ptosis and diplopia is an early sign, followed by the bulbar muscles, which are involved in swallowing and chewing, and then the face, neck, limb girdle. And this manifests with dysphonia and difficulty moving the limbs. There's an association with thymic hyperplasia, worsens in pregnancy, as well as hypokalemia, and D-penicillamine used for rheumatoid arthritis can cause myasthenia gravis as a side effect. The important investigations are to search for the antibodies, the anti-nicotinic cholinergic receptor antibodies, which are present in about 90% of cases. The other important antibodies are the anti-MuSK antibodies or the anti-muscle specific tyrosine kinases. Due to the association of thymic hyperplasia, a CT of the thymus is important. A tensilon test used to be used where 10 milligrams of intravenous edrophonium, which is an anticholinesterase, was administered to see whether power would be improved. Neurophysiology detects a decreased amplitude on repetitive movement. Patients with myasthenia gravis require long-term management. Symptom control can be achieved with regular anticholinesterases such as pyrostigmine, which tries to keep acetylcholine in the synaptic cleft for as long as possible. They may require immunosuppression to help with this autoimmune condition with drugs such as prednisolone, azathioprine or methotrexate. A thymomectomy can help remission and reduce local compressive effects of an enlarged thymus and also prevents tumour spread. If a patient develops a myasthenic crisis, and that would manifest as excessive salivation, confusion, lacrimation, meiosis, pallor, collapse, edrophonium would be avoided, and they would undergo intravenous immunoglobulin therapy, plasmapheresis, and if the respiratory muscles are affected, they would require ventilatory support. Now, a similar condition to myasthenia gravis is Lambert Eaton syndrome. Also known as Lambert Eaton myasthenic syndrome. This can be paraneoplastic mediated by small cell lung cancers. And this is where instead of antibodies against the postsynaptic nicotinic cholinergic receptor, these are antibodies against the presynaptic voltage-gated calcium channels. And in this condition, the groups of muscles that are affected are the limb girdle before the ocular muscles, and patients are typically hyporeflexic, and power increases with repetitive stimulation. And the management is similar, and intravenous immunoglobulins and regular high-resolution CT scans to screen for small cancer. This condition, also known as Lambert Eaton myasthenic syndrome, can be as a result of small cell lung cancer as a paraneoplastic condition. Unlike myasthenia gravis, where the antibodies are against postsynaptic nicotinic cholinergic receptors, in this condition, the antibodies are against presynaptic voltage-gated calcium channels, and the muscles that are involved are the limb girdle before the ocular signs. Patients are classically hyporeflexic, and power increases with repetitive stimulation, unlike myasthenia, where repetitive stimulation decreases power. Management is with intravenous immunoglobulins, and patients undergo cross-sectional imaging to screen for small cell cancers. Thank you for attending this medicine masterclass.